Good morning, everyone. And today we are going to discuss renal functions. And as you know, my previous lecture was about hypo and hyperkalemia. And this one is about renal functions. Why? Because they are quite interconnected. And also, like, we have to done renal functions anyway. So that's why I make it as a continuation of that thing. The kidney is doing a lot of functions in the body. They are producing they are excreting the waste products. They are maintaining the acid base balance, they are maintaining the electrolytes, they are maintaining the water balance, they are doing some functions like producing erythropoietin and like which produces RBCs and like this is a hormone, of course, like. And they do have some metabolic functions, like not so important, but of course, um, like they have some role in glycogenolysis and glycogen storage, but like that we don't count at all. Okay. One of the thing, it's very important to know the normal functioning of the kidney, because if you don't know the normal functions, how it maintains the calcium, how it maintains the phosphate, sodium, potassium, and things like this, of course, uh, it will be hard for you to understand what are the renal, like what, how, why, what functionings, what we are testing. It won't be easy for you to understand. So the important thing over here is, the functioning unit of the kidney is nephrons, and the nephron, um, on an average, there is how many nephrons in the kidney, like combined, both of them, like one of the kidney is around 1 million, have 1 million. By the way, more than 1 million, right? But you can say like, okay, um, on an average, both of the kidneys have 2 million neurons, right? And sorry, nephrons. And nephrons are basically the functional unit of the kidney. And if you know, like, what are the um, nephrons, how they look like, what is glomerulus, what is Bowman's capsule, what is afferent and efferent arteriole, what is the proximal tubule, loop of Henle, distal tubule, as well as collecting duct. I'm just telling you these things because, of course, this is a lecture about lab diagnostics, but very important, you must know these things before going or listening to this lecture. Now, why the renal functions are important? Because the renal functions um, uh, are simply we do to see how the kidney is functioning, and to see like if there is any, you can say, abnormality in the normal physiology. And one of the things which we check is basically GFR, which is glomerular filtration rate. As we know, like our kidney, on an average, on daily basis, it almost um, filter around 180 liters of blood, and out of them, 1.5 liters produce as urine. Now, the important thing, like one of the thing here is basically creatinine, and one thing is called as urea. Now, um, if you know what is urea and creatinine, basically creatinine is produced by the muscles, okay, and the creatinine will be more simply when the muscle mass is more. So simply in males they produce more creatinine, and the females they produce less creatinine. Um, One of the thing, because creatinine is produced as a byproduct of muscle metabolism, and this one is excreted by the kidney unchanged. Okay, so that makes it as a good thing to measure, to estimate the GFR, or glomerular filtration rate. But there are many problems with this thing. Why? For example, someone who have more muscle mass, of course they produce more creatinine. Someone who have less muscle mass, they of course they produce less creatinine. So that's the problem with this thing. uh, uh, if you have done Guyton, in that one, if you remember, there is something when they explain GFR, they explain inulin. Okay, so inulin Basically, it's a polysaccharide, and inulin is the best thing because it goes unchanged and the kidney can throw it out. But uh, we use creatinine because it behaves like um, inulin. Okay. Except like there is some secretion of creatinine, so that makes it a little different, but that's fine because we don't have any other option. Urea, of course, like the urea is again one of the things which is produced in the body. And urea is basically, you can say, um, the byproduct, okay, or the product of the protein metabolism or nitrogen metabolism. Okay. um, so what happens is basically there is urea cycle which you have done in biochemistry. If you remember urea cycle, things will be easy for you, because the ammonia, which is quite new, like which is a neurotoxic, or which is toxic to the body, is basically changed to urea, and then the urea is thrown out from the body, right? So we measure urea and creatinine simply um, to check for the renal function test. So of course the excretion of the urea is done by the kidneys. Okay. So what you can say, it's a nitrogen waste product. Okay. But then urea also plays some other um, functions in the body as well. So of course, like, we are not going to discuss them right now, rather we will talk about more and more about the renal functionality. Now the problem is what? We have 2 million nephrons in our both kidneys. For the kidneys to work fine, or to maintain the level of urea and creatinine in the blood, basically you don't have all your kidneys to work properly to do this thing. Rather, if only 20%, by the way, less than 20% of your nephrons are working, which means even if your um, 400,000 nephrons are working, guys, your creatinine and urea will be completely fine. That's the reason that people, they can uh, donate their kidney and they can still live a happy and healthy life. So that's the reason the creatinine, the presence of the normal urea as well as the creatinine level is not synonymous. You can say the presence of normal urea and creatinine are not synonymous with normal renal function. What I mean to say here, I told you that if your kidneys are failing, but still you have enough nephrons to maintain the renal functions, your urea and creatinine will not raise. But when your urea and creatinine will start raising in the blood, it means already a lot of damage is done. Okay. So uh, I already explained you what is creatinine. A thin woman, a thin woman. Um, we can take example like this thing. For example, a thin woman and you can say uh, muscular guy, who had done a lot of gyms, man. Okay, this one is producing a very less creatinine, but this one is producing a lot of more creatinine. So maybe if this man creatinine is high and this woman creatinine is high, it means, and both of them their creatinine is high and at the same levels, it means that this woman kidneys are much more damaged than this guy. Why? Because she's producing very less creatinine and still her creatinine is raising, but this guy who have a muscle bulk, of course, like, if his levels are same level at like that woman, so of course, like, it means he's like his kidneys are well preserved than that woman. So how we measure the renal function, we have to estimate the glomerular filtration rate. Okay, glomerular filtration rate. Okay, so now of course what we do, like nowadays whenever you are going to send anyone for renal functional test, okay, they will give you a report like this, EGFR. Okay, so what is EGFR? Is simply E for estimated, that is estimated, um, GFR. Okay, so an estimated GFR is like now routinely reported by many laboratories, simply to highlight the importance of small increases in creatinine. Okay, as I told you, uh, when the creatinine is increased, it means like there is already significant amount of damage is done. So uh, the important thing over here is like most of the labs, they have a cutoff value. So for example, if someone GFR is falling below some certain cutoff value, they say like the GFR is reduced. Okay, you can say uh, the estimated GFR, how the report is by this way. They will give you a report, for example, greater than 60 milliliter per minute, um, per, you can say 100, 173 or 1.73 73 meter um, square. Okay, so meter square, like this is the mass of the body. So when like it is more than 60 milliliter per minute per 1 point, like 1.73 meter square, it means like you could say the kidneys are functioning well. uh, by the way, what's the importance of this thing, because you haven't done any clinicals, um, renal failure, GFR, you can say. Um, I will show you something over here, just to tell you what's the importance of this thing. See, whenever we are estimating like someone have renal failure or not, guys, how they report things is by this way. They make a, okay, wait, they, I'm sorry, wait, I will show you. Yes, I will show you this one. See, they say like stage 1, stage 2, stage 3, stage 4, stage 5. So see, stage 1 when the GFR is more than 90, stage 2 when GFR is 60 to 89, so mildly decreased function, stage 3, stage 4, stage 5, like this way, right? So simply they sorry, they explain that they write the things like this way. Okay, so remember guys, one very important thing to remember over here is wait, one very important thing to remember over here is basically um, this one. Normal GFR is considered to be approximately 100 ml per minute per 1.73 meter, um, of course, square. Okay, so this is like the normal GFR, and I'm going to make it in, like, just to tell you the importance of this thing, right? uh, Now, how we estimate the kidney function, like, as I told you, like most of the labs, they now report EGFR, estimated GFR. So now here, you can say a lot of mathematics will come, how they calculate. Okay, um, I will show you over here how they calculate, but wait, again, I have to take the help of Bing. Okay, and estimated GFR. Okay, so images, you will found a calculation. Okay, see there are formulas like um, Cockforth, you can say Gall formula or modification of dietary renal disease formula, right? Or you can see over here, um, like this is you can say equation which they use. So GFR is equal to 186 multiplied by serum creatinine multiplied by the age in years raised to the power 0.203. So simply they what you can see over here is like they calculate by using serum creatinine, and they check the patient age, okay, and they always check the patient sex, and they also check the patient race. Why sex and race? Because for example, if it's a female, so they multiply it with a different factor, and if it is like for African race, so they multiply it with a different factor, okay, because we have like some different functionality simply. Okay, so this is like how they use, and I show you like two formulas right over here. So you can say if you know like what is the age of that person, what is the sex of that person, and what is the race of that person, and you know the creatinine value, you can simply calculate the estimated GFR. Okay, now uh, GFR, or you can say the creatinine clearance, is a useful indicator simply to indicator of you can say the GFR, glomerular filtration rate. What we do is basically like we do another way which is called as creatinine clearance. Okay, and again like there will be again a mathematical formula. I have to open Bing today again and again because you don't have to remember these things, but like just to show you, there are online calculators as well, but I will show you rather a figure like this one. This one, okay. So this is like one of the formula. This is one of the formula. You can see, um, sorry, like creatinine clearance is done by this formula, okay, where CL, this one CLCR, okay, or CCR is the creatinine clearance in milliliter per minute, and UCR is concentration of creatinine in urine, okay, and this V, or some people they write it as U, this is the urine flow rate, and P is like the concentration of creatinine in plasma. And you see like they have calculated a person has a plasma concentration of this one in 1 hour producing 60 ml of urine with a creatinine concentration of 1.25. So see 1.25 they put here, okay, because this one is the concentration of the urine, this one is the urine flow rate, okay, 60 milliliter per minute they put it over here, this is the concentration in the plasma, that is 0.01, and this is how they calculate, and they found like the creatinine clearance is 125 milliliter per minute, which is completely normal. Okay, so this is the formula, creatinine clearance formula. Now there are some difficulties with this method. uh, what are the difficulties? Of course, like the plasma creatinine is measured in micromole per liter, not millimole per liter. So we have to convert that. Nowadays, of course, it's not a problem because online converters are available. Second thing, which is the difficult thing in this one, because it depends on the urine flow rate, which is usually measured in liters per 24 hours. Okay. So, or you can say the amount of urine produced in 1 day, or in 1,440 minutes. In 24 hours, there is 1,440 minutes. So, of course, like um, um, when we have to calculate the urine rate, so we have to, mm, you can say, use some correction factor, okay, uh, to adjust that. So the factor is basically the correction factor is 0.694. So anyhow, this is how we check. And the other one is there is one more formula by we can check the creatinine clearance. Okay, the one which I showed you before. Next thing is serum urea. Okay, so guys, understand like this thing, when the GFR is reduced, so like the creatinine clearance is reduced, it means like the GFR is reduced. Why we are doing creatinine is simply to check like either the GFR is normal or not. Now the urea, serum urea, again there are many issues with serum urea as well. See, from where the urea comes, if you remember urea cycle, it depends on how much, for example, production is there of urea. What is it that this one is basically, the urea is produced by liver. So for example, someone who have liver failure, they will produce less urea. So see, someone who have liver failure with renal failure, of course their urea will be normal. Why? Because the urea will not be present in the body, rather there will be ammonia, which is harmful for the body. Other thing is the diet. If you're taking a protein rich diet, of course you are going to produce more and more urea. If you are going to take protein deficient diet, of course you are going to produce less urea. Okay, so whenever there is renal failure, so what will happen, of course the urea is going to raise. Again, I will show you how a renal function test report looks like. Okay. Um, See, they measure creatinine, they measure urea, okay, they measure total protein. Why? Because when the kidneys they are failed, they become leaky, they cannot hold protein in the body, so the protein will start leaking, and there will be hypoalbuminemia in the body, or hyperalbuminuria, like there will be more and more there will be proteinuria, like the proteins will be present more and more in the body, and they will give you all the electrolytes, not all the reports, but here they have given. Okay, so of course like electrolytes we have done. So this is how it looks like. So remember guys, serum urea also is used to diagnose the renal function test, right? But serum urea depends on many factors. Okay, so in renal failure, simply the urea is raised. So you can say in renal failure, both urea and creatinine will be raised simply. Okay, so now the urea can also be raised in GIT bleedings, because for example someone who have a bleeding in the GIT, what will happen? Blood is what? Blood is a protein, so that will produce more and more urea simply. Okay, one of the thing um, which we check is basically plasma osmolarity. Now I already talked about this one. Okay, uh, how we calculate plasma osmolarity, guys, it's very interesting. I will tell you the equation first, then I will talk about that. So how we calculate plasma osmolarity is, it's by this equation. Plasma osmolarity is equal to 2 multiply by, or x, we can put x, 2 multiply by um, um, plasma. Um, okay, yes, I know how to put this thing. So sodium, okay, plus um, plasma potassium, okay, sorry, um, plus plasma urea plus plasma glucose. Now, this is how we measure plasma osmolarity. So, to measure plasma osmolarity, what things you need? You must know how much is the sodium in the sodium ions in the plasma, how much is the potassium, how much is the urea, how much is the glucose. Okay, now pay attention on this thing. Sodium is basically extracellular ion. Potassium is basically intracellular ion. What is the normal value of sodium, guys? In the previous lecture, I told you it is 135 to 145. How much is the normal value of potassium? It is 3.5 to 5. How much is the normal value of urea? Very, very, very less. And how much is the normal glucose level? Very, very, very less. Okay, even if they are more. See, when we are adding 140, for example, with, for example, 4, so at that will make how much? 144. And we are multiplying it by 2. So how much is that? 200. 144 multiplied by 2 is how much? 288. So if you remember, what is the normal plasma osmolarity? It is between 280 to 290. So see, this is basically the sodium ions which define the osmolarity of the plasma. In clinics, we can simply take the sodium value multiplied by 2. So that gives you roughly the osmolarity of the plasma. Of course, we add the urea and glucose as well. So simply, serum osmolarity can be calculated by this equation. Okay, so it is the sodium, you can say, it is the most influential. When the sodium will change, osmolarity will change, except in some of the condition. For example, when there is very too much glucose in the blood or hyperglycemia is there. Okay, but normally if you know sodium, or you can say it is the sodium which is highly influential. So this is how we calculate plasma osmolarity. I'm talking about this thing because we are doing renal function test, so that's very important, because kidneys are also the one which are maintaining the sodium ions. Kidneys are also the one which are maintaining the plasma osmolarity. So this thing is important. And one of the thing, okay, because I did not talk about the other ions before, but we say something called as um, nutritional profile. Okay, so why we do nutritional profile, guys? Because okay, what they do in nutritional profile, I will tell you. They measure, um, you can say, it comprises of, what they measure is magnesium, they measure calcium, they measure phosphate. Okay, they measure albumin. Okay, and if you remember, like I show you that RFTs, right? And in that one, if you remember, they give you the albumin, they give you the magnesium, they give you the calcium, they give you the phosphate. Why? Guys, in patients with poor nutrition, all these things will be deficient. A person who have poor nutrition, who is malnourished, their magnesium will be low, their calcium will be low, their phosphate will be low, their albumin will be low. So, for example, in alcoholics, or in the people who do hunger strikes, they don't eat anything. When you will check their bloods, you will find like all these things are low. Okay, so simply you can say in malnutrition, all these are low. So that's why we call it as nutrition profile. Okay, and there are other things as well, guys, which are called as micronutrient. For example, selenium in blood. There is a very small trace of selenium also there, but we don't measure that. So, not just in malnutrition. For example, some of the patient may have um, malabsorption. Of course, when there is malabsorption, whatever you are eating, if it is not absorbed, so all this thing will be low. And whenever someone have a bad nutritional profile or a bad uh, nutritional status, what we do? We refeed them. Okay, and when we refeed them, there is a term called as refeeding syndrome which can occur. So whenever, for example, hunger strikers or someone who was in a chronic disease, he's not eating anything, and now he's becoming better, and now you started refeeding him. So sometimes they can develop something called as refeeding syndrome. Refeeding syndrome. Okay. So uh, what is refeeding syndrome? Like, these are basically the changes in the blood biochemistry which occur when you start feeding them. For example, when someone, for example, who was on a hunger strike for so long, and now they started eating. Okay. Or someone, for example, who had stroke and he was not eating for a while, and now he started eating again, they may have refeeding syndrome. What is refeeding syndrome? Because sometimes there could be dangerous shifts in many electrolytes. For example, um, these people may have uh, deficiencies of not just deficiencies, by the way, excess of as well. So of phosphate, okay, as well as magnesium, okay, as well as calcium. Okay. So all like, there could be, they may have hypophosphatemia, they may have hyperphosphatemia, they may have hypomagnesemia, or they may have hypermagnesemia. Okay. So that's why whenever like we are doing refeeding any patient, we keep on checking their profile for these things. So this is like the nutrition profile, which can be done with RFTs. Okay. So the last point, guys, which I wanted to talk about in this in like renal patients, is basically the urine in acute renal disease. Okay. Diseases, because there are many diseases. So that's why, of course, like, you don't know about the renal diseases right now because you haven't done the internal medicine, but there are many renal conditions, of course, in which like these things can occur. So why this thing is important? Because acute renal failure is a common problem in clinical practice. Okay. So you can see a lot of patients with renal failure or acute renal damage or acute kidney injury. Why? Because see, whenever for example, someone have hypotension, so of course, like, when not enough blood is going to the kidneys, or there is hypoperfusion to the kidneys, so they may have acute kidney injury. So now we analyze their urine, right? So urine we analyze for electrolytes, of course. We analyze urine for electrolytes. Okay. Now I will tell you a very easy example, easy thing about this thing. Okay, and maybe you can remember it, like when you will study the kidney disease as well. Now, one of the things, whenever there is any acute kidney injury, depending on what is the cause, for example, someone who have shock or someone who have hypoperfusion or hypotension, they will be having what kind of renal injury? Pre-renal injury. Why? Because see, the problem is before the kidney, there is not enough blood going to the kidney. Or for example, someone has taken too much drugs like NSAIDs, so that is damaging the kidney or causing acute tubular necrosis. So it means like that drug is damaging the tubules of the kidney. We call it as acute tubular necrosis, or you can say like this is a renal type of acute kidney injury. And there could be post renal injuries as well. Okay, so there are three types. Okay, so in clinics, post renal, of course, like, there could be stones, there could be trauma, there could be tumors. We mostly do imagings, and we are not discussing images, so we are not going to discuss this one. But pre-renal and renal, remember, in pre-renal there is not enough blood supply to the kidney, but in renal one there is a damage to the kidney itself. So we can differentiate easily by doing some testing or by checking the electrolytes in the urine. What electrolyte? Sodium. Either it's a pre-renal or either it's renal one. See, the key to correctly interpret or correct interpretation of urinary electrolytes is understanding that pre-renal uremia. Pre-renal uremia means what? Like when the condition is pre-renal, like hypotension or shock, and uremia is what? And the urea is raising in the blood. It means like your kidneys are not throwing the urea out. So this one, in pre-renal conditions, conditions, or pre-renal uremia. I will use uremia. Remember guys, remember the kidney regulatory mechanisms are normal, okay, and they can maintain the heme homeostasis, okay. So what happens, by the way, because now the kidneys are normal, so there is a juxtaglomerular apparatus which senses that there is less renal blood flow. So what is activated? Renin, angiotensin, aldosterone systems will be activated, okay. And when this system will be activated, what will happen? What the kidneys are sensing? Less blood flow is coming. So kidney will sense some hypoperfusion state or hypovolemia is there. Renin, angiotensin, aldosterone system will be activated. Aldosterone will do what? It will retain sodium. So when it will retain sodium in the body, urine will be having less sodium. Guys, remember this thing. So when you take the urine and you analyze the sodium in these patients, what you will found that they will be having less sodium in the urine. Why? Because the body, the kidneys, they are preserving the sodium. So simply, it's a juxtaglomerular apparatus which sends and renin, angiotensin, aldosterone system is activated, and the aldosterone is there to cause the sodium reabsorption in the distal convoluted tubules, okay, and there will be increase in the circulating volume. So remember that in pre-renal uremia, sodium will be low, or urinary sodium will be low, less urinary sodium, okay. A very, very, very important point. On the other hand, or on the contrary, I am going to discuss like the other condition, for example, that is the renal uremia, like when the cause is in the renal. For example, I told you someone who takes some drug and that damages the kidney itself, or it causes acute tubular necrosis, okay. So what will happen in acute tubular necrosis? That now the normal physiological mechanism of the kidney is lost, okay, or is not functioning properly, okay. What will happen now? The important thing over here, either the kidneys can retain sodium, no, so the urinary sodium will be higher, okay. So that's how we can differentiate either it's pre-renal or either it's renal. But guys, like there are some difficulties with this thing as well. For example, someone who is on diuretics, because diuretics, what is the function of diuretics? They will throw out sodium anyways. So then in that case, of course, you can say always rule out that the that if the patient is taking diuretic, okay. So this is the important thing, okay. So what we call it as, we call it as FENA. What we call it as, what is FENA? It is basically fractional excretion of sodium, okay. It is called as what? Fractional excretion of sodium. So this is a simple measurement, they can do, and they can tell you, and they simply check, like they measure the proportion of the sodium that is filtered at the glomerulus and appear in the urine, okay. So remember that FENA, it will be low in pre-renal uremia but high in renal or acute tubular necrosis, okay. So this is the important thing, guys, which I wanted to tell you. So thank you so much for listening, and in the next lecture we are going to discuss about more lab diagnostics. Thank you so much, guys.